Welcome to the Prostate Forum of Orange County, California. Tonight's presentation by Dr. Sandy Liu of City of Hope, Orange County in Irvine, and the UCLA Medical Center is called Oncology View of Prostate Cancer, featuring intensification of therapy in advanced disease. We are delighted to have the doctor here for her very first time. For those of you new to us here, we have two support group meetings. We have something we call Newly Diagnosed, but we're kind of flexible about that. It meets every second Tuesday of the month at 5 p.m. Pacific, goes to about 7 p.m. Pacific. And then we have our advanced group. And again, we're kind of flexible about what we mean by advanced. If you got to get support, come on in either way. And that group meets on the fourth Tuesday of every month via Zoom at 5 p.m. Pacific. We never do medical advice here. We share our personal experiences, and we hope you join us. Dr. Liu is Assistant Clinical Professor of Oncology. She received her medical degree from George Washington School of Medicine. She practices at City of Hope and UCLA. She has done research in the United States and in China, and is fluent in Mandarin. With that, and no further ado, we are excited and delighted to have Dr. Liu with us, and I will shut up and give you the meeting.
So good evening. It's really my pleasure to talk to you about, in this forum, a very important and practice-changing topic on the treatment intensification strategies for metastatic hormone-sensitive prostate cancer, also known as MSHPC. And I know we have a Q&A session at the end, but this discussion is really meant to be interactive. So please feel free to interrupt me at any time or send me your questions in the chat throughout the presentation. So here are my disclosures. So let's begin by talking about epidemiology, just to put this disease in perspective. So on the right-hand side, you can see that prostate cancer is the #1 leading cancer incidence in men. Approximately 249,000 men are diagnosed each year. And down below, prostate cancer is the second most common cause of cancer death after lung cancer in men. And most patients, they're diagnosed by an elevated PSA screening, and they're detected usually at a curable stage. We know that there's a higher incidence and death rate in African Americans. And if patients have a first-degree relative diagnosed with prostate cancer, they're at 2 times the risk of developing prostate cancer. And if more than 2 relatives are diagnosed before the age of 70 years old, they're at 4 times the risk of developing prostate cancer. Prostate cancer can also have associations with occupations and exposures, and a healthy diet is important for preventing recurrence and progression of disease. So I want to first set the stage by describing the clinical state of prostate cancer. We want to know, first of all, if the prostate cancer is confined to the organ or if there is spread locally around the prostate. That's locally advanced. So both the organ confined and locally advanced disease can unfortunately have a rising PSA and go on to develop metastatic disease. And unfortunately, there's a portion of men who present with de novo metastatic disease. They are hormone sensitive. And after treatment with hormone therapy, ADT, they can progress and develop into castrate-resistant disease. But for this talk, I'm just going to focus on the metastatic hormone sensitive setting. So first, it's really important to define what it means to be high volume versus low volume and high risk versus low risk. So because it can factor into my decision-making of whether to use doublet versus triplet therapy. So for high volume disease, this was really defined in the charted clinical trial criteria. And high volume disease is defined by the presence of visceral metastasis, and that's usually either liver or lung metastasis, and more than 4 bone metastases with 1 or more bone lesion beyond the vertebral column or the pelvis. And that's high volume disease. High risk disease is defined by the latitude criteria, and that's greater than 2 risk factors, which includes Gleason score of greater than or equal to 8, 3 or more bone metastases, and visceral metastasis. So what are the unmet needs for metastatic hormone-sensitive prostate cancer? Well, patients with MS-HPC really have poor clinical outcomes. And the biggest challenge we are still facing is that the disease remains incurable. And this is an area that we're really undergoing active and exciting research investigation. We know that survival is related to the type of presentation. If they present with de novo versus recurrent disease, as well as the way the metastatic disease is distributed, with whether it's visceral metastasis versus bone metastasis versus lymph only, and the extent of metastatic disease. And there's now clear and compelling evidence, level 1 evidence, that intensification of systemic treatment improves overall survival. And you'll probably hear me say this multiple times throughout the presentation, that ADT alone is inferior in terms of disease control and survival, as well as quality of life. So again, despite level 1 evidence for improved overall survival, real-world evidence shows that there's really been poor adoption of treatment intensification in this important disease state. And it's really frustrating to think about why and how this is happening. So in a population-based study of patients in the United States with de novo metastatic hormone-sensitive prostate cancer from 2014 to 2019, only 12% of patients received intensified treatment. And there's another analysis from the VA claims data that reported most men with metastatic hormone-sensitive prostate cancer who initiated treatment from 2014 to 2018 were treated with ADT only. And there were similar findings reported for over 800 patients with metastatic hormone-sensitive prostate cancer from US-based oncology practices, and chart reviews of over 600 patients with metastatic HSPC initiating treatment from oncologists as well as urologists showed that about half of the patients did not receive intensified treatment approaches. So again, if you leave with only one message, it's really that ADT alone is insufficient for nearly all patients with metastatic hormone-sensitive prostate cancer. And this slide shows the clinical outcomes in men with metastatic HSPC treated with ADT alone. So the Stampede study is a really interesting trial design. It was a multi-arm, multi-stage trial design where there were multiple arms added to the standard of care, which is ADT. And this is data from the Stampede experience with ADT alone. This is making a very clear point that patients with MS-HPC treated with ADT alone have poor clinical outcomes. So there's over 1,000 patients enrolled in the Stampede trial between October 2005 and January 2014, and the control arm is treated with ADT alone. And what they found is these patients that were treated with ADT alone, the median overall survival was only 42 months. Strikingly, the time to failure, which was defined as PSA progression, local progression, distant metastasis, or death, was less than 1 year. And the progression was really related to the sites of metastatic disease. And as you can see from the graph on the right, patients with soft tissue disease, which is lymph node only, did the best. Patients with bone metastasis did worse. And patients with bone and soft tissue metastasis did the very worst. And here is a survival by presentation of extent of metastatic disease. So previously, I described high volume versus low volume, and now I want to layer on top of that recurrent versus de novo disease, because there's really clear data that disease stratification will allow us to project the clinical course as well as the prognosis for the patient. So recurrent disease is really defined by progression after definitive therapy, whether it's surgery or radiation. And de novo disease is initial presentation of metastatic disease. So this is data from 2 large studies, Charted and GTUG 15 clinical trials. And what they showed is that the expected median survival ranges from about 8 years in patients with recurrent low volume disease to only about 3 years with de novo high volume disease. And if you look at the in-between groups, recurrent high volume, it's 4.5 years, and the de novo low volume, the median overall survival is the same at 4.5 years. And notably, US hospital registry data showed that about half of the patients of low volume metastatic hormone sensitive prostate cancer is recurrent metastatic disease. And only 15% of patients, they relapse with high volume disease after prior surgery or radiation. So there are a lot of factors I think about in terms of making treatment decisions and considering the role of intensification with patients. So I think about cancer-related factors. I look at what their extent of disease, metastatic disease is. Is it de novo versus recurrent disease? Have they had any prior treatments? And what is their molecular features, their genetic testing? I also look at the patient-related factor. Who is the patient sitting in front of me? What is their life expectancy? Are they expected to survive 10 or 15 years? Or do they have a life expectancy of 2 to 3 years because of other comorbidities? I think about concomitant medications because sometimes we can have drug-drug interactions. I think about the performance status, the overall fitness of the patient. And if they have any presence of symptoms, do they have pain that I need to address? Do they have any weight loss or any other symptoms? How is their social support? Do they have a supportive environment at home? Because that's where they spend the majority of the time. Do they have access to transportation and things that, help me treat them better? And also their preferences and beliefs. I also look at their treatment-related factors. What are the availability of treatment, their schedule and of treatment and monitoring, the financial burden, the cost, the expected efficacy and toxicity. I look at all those factors. And lastly, there are clinician-related factors. It's how comfortable we as clinicians have experience with treatment options, our comfort with adverse event management, our interpretation of clinical trial data, and our own preferences and belief. That all factors into our decision-making. So now there are multiple studies, level 1 evidence, that showed intensified therapy is associated with improved overall survival for metastatic hormone-sensitive prostate cancer. And here's a table of a summary of the most of the data we have from randomized controlled trials. And these studies have shown consistent, compelling evidence for improved overall survival. And they're grouped according to intervention. So let's first talk about the docetaxel group. So if you look at GTUG 15, Charted, and Stampede Arm C, these studies looked at the addition of docetaxel to ADT and concluded that there's a benefit of adding docetaxel chemotherapy to ADT, mainly in the high volume subgroup. And next, Latitude Stampede Arm G looked at the addition of abiraterone to ADT, noting that there are similar benefits across different risk groups. And then there are a number of other studies looking at different androgen receptor targeting agents, such as enzalutamide in the ARCHES and ENZAMET study, as well as apalutamide in the TITAN study, which again, all showed consistent overall survival benefits across different risk groups. So we now also have data in the triplet trials from the Arisons as well as the PEACE-1 showing that, in addition to ADT plus docetaxel, adding either darolutamide or abiraterone improves survival compared to just ADT alone. And we also have to remember that ADT also plus radiation to the prostate in the low volume metastatic hormone sensitive prostate cancer is also associated with improved overall survival. And this was shown in the STAMPEDE Arm H group. And we found that this was really quite game-changing when I heard about this because, you didn't realize you can radiate the primary prostate in patients with metastatic disease. And now in all patients with low volume metastatic disease, I have a discussion regarding radiation to the primary prostate. So in essence, there are multiple combinations that suggest improvement in overall survival over ADT alone, which again should not be the standard of care for metastatic hormone-sensitive disease. So before I go on to talk about clinical trials for doublet and triplet therapy, I want to discuss the role of prostate radiation to the patient with de novo metastatic hormone-sensitive disease. As I mentioned earlier in the table, we have evidence from the STAMPEDE Arm H that the addition of radiation to the prostate improves survival in the low volume subgroup. And you can see that on the graph on the right, that when adding radiation to the to ADT and abiraterone, you can see that improved overall survival over the control arm. But in the high volume subgroup on the right, you can see that adding radiation to the prostate did not improve overall survival. And it intuitively makes sense because when you think about it, in the high volume subgroup, most of the disease is outside of the prostate. So radiating the prostate will have less or really no role. Whereas in patients with low volume, the bulk of the cancer is in the prostate. So you might really anticipate an overall survival benefit if you radiate the prostate in a low volume group. So now I want to talk about pivotal trials of doublet treatment intensification, and that includes ADT plus an AR targeting agent. So I want to talk first about docetaxel chemotherapy. So ADT alone was used to be the standard of care until 2015, where docetaxel chemotherapy was brought to the front line with ADT. Now, docetaxel was initially approved in the castrate-resistant setting and really shown to have a modest benefit in the castrate-resistant setting. But there are now two large randomized control trials, the CHARTED and the STAMPEDE, that showed an overall survival benefit for the addition of docetaxel chemotherapy in metastatic hormone-sensitive prostate cancer. So CHARTED was a large cooperative US group trial, and patients were randomized to ADT alone or ADT plus 6 cycles of chemotherapy, docetaxel. And the primary endpoint was overall survival and progression-free survival. So CHARTED was one of the first trials that highlighted the definition of volume of disease, high versus low volume. And that's where we got the understanding that high volume benefited more from docetaxel chemotherapy than low volume. So if you look at the graph on the bottom right for CHARTED, you can see that adding docetaxel to ADT improved overall survival by 13 months compared to ADT alone. And if you look at the graph on the top right, patients with high volume disease, the magnitude of benefit was higher, a 17-month improvement in overall survival. And on the left, the Stampede trial also showed that the addition of docetaxel to ADT showed an improvement in overall survival of 10 months compared to ADT alone. Now, there are two trials that came out the following year with abiraterone that also was associated with improvement in overall survival. So like docetaxel, abiraterone was approved initially in the metastatic castrate-resistant setting and has now moved earlier in the frontline space. So in the Latitude trial, adding abiraterone to ADT improved overall survival, and the hazard ratio was 0.66. And in the Stampede Arm G trial, it also showed that the addition of abiraterone to ADT showed an improvement in survival with a similar hazard ratio. So this slide compares the Stampede Arm C, which was ADT plus docetaxel, and Stampede Arm G, which was ADT plus abiraterone. And this showed that there were no differences in overall survival between the two regimens. So, you can use docetaxel or abiraterone up front. So it really gives us a second option for patients who don't want to do chemotherapy. The benefit of abiraterone to ADT also offers these men an improvement in overall survival. So based on this data, we can comfortably choose either agent up front. So now we have other trials, Enzamet, Arches, and Titan, that were the next wave of trials looking at other AR blocking agents, such as enzalutamide and apalutamide. So Titan was a phase 3 randomized control trial of ADT plus placebo versus ADT plus apalutamide. And this study showed an improvement in overall survival at 24 months for apalutamide with ADT compared to placebo plus ADT. And the Arches and the Enzamet trial looked at the addition of enzalutamide plus ADT compared to ADT plus placebo or ADT plus bicalutamide in the Enzamet trial. And there was also a similar magnitude of benefit in terms of overall survival improvement favoring enzalutamide in both of the studies. So again, both showed that ADT plus enzalutamide were a better combination. So Arches showed that enzalutamide plus ADT had an improvement in overall survival compared to placebo plus ADT, and it significantly reduced the risk of radiographic disease progression by 61%. So upfront intensification is really the new paradigm in metastatic hormone-sensitive prostate cancer. When I counsel patients, I tell patients that, you really get the most bang for your buck when you use these agents earlier rather than waiting to use them later. So I try to be really aggressive upfront to have the best survival and outcome. So really, there's a survival benefit that's seen when you use it in the metastatic hormone-sensitive setting rather than in the castrate-resistant setting. So for patients whom doublet is preferred, ADT is added to one of the androgen receptor targeting agents, whether it's abiraterone or apalutamide or darolutamide or enzalutamide. And if patients are eligible for triplet therapy, we give ADT plus 6 cycles of docetaxel and add on our AR targeting agent, whether it's darolutamide, abiraterone, or enzalutamide. And if patients who did not have primary treatment to the prostate, if they have low volume disease, I always consider radiation to the prostate primary. So now why do we need triplet therapy? So in Latitude study, we saw that only 55% of patients achieved a PSA nadir of less than 0.2 with abiraterone and prednisone. And if you look at the graph on the right, this is the red line for greater than 90% responder, and they had the best survival. They achieved a PSA nadir of less than 0.2. The green line were those between 50 and 90% responders, they had a decline in survival. And the purple line were those patients who had a less than 50% response, and they had the worst survival. So at least 20% clearly needed something more beyond abiraterone and prednisone. So we want to aim for a cure, obviously, and find a treatment plan that doesn't require lifelong castration. And for us, we have treatment intensification using docetaxel. It's a finite treatment. We only do 6 cycles of docetaxel. So that's where Ariston's and Peace 1 trial came. They were opportunities to explore further intensification in these men. So the Peace 1 trial, this was a complicated trial, but it was a phase 3 study. It was a multi-arm study that really was asking 2 questions. The first question was, should we add abiraterone on top of standard of care ADT plus docetaxel? That was the first question. And the second question they wanted to ask is, should we use radiation to the prostate primary when we are intensifying treatment? So patients who had de novo metastatic hormone-sensitive prostate cancer, they were randomized 1:1:1:1 to the 4 treatment arms. And the primary endpoints were radiographic progression-free survival and overall survival. And this slide shows the radiographic progression-free survival improvement with ADT plus docetaxel plus abiraterone at 4.5 years, compared to only 2 years with standard of care ADT plus docetaxel. So really, you can get an additional 2.5 years of good life to patients without disease progression using the triplet combination. And when you look at overall survival with the triplet, you'd see there's an improvement in overall survival with the 3 drugs compared to the 2 drugs. Next, they also looked at the triplet therapy in the Ariston study. So approximately 1,300 men were randomized in the study. They were randomized to either darolutamide plus ADT plus docetaxel for 6 cycles, or placebo plus ADT plus docetaxel. And the graph below shows a significantly improved survival with darolutamide in addition to ADT plus docetaxel compared to placebo plus ADT and docetaxel. And you can see the curves separate with time very nicely. And the hazard ratio is 0.68, which really translates to a 32% reduction in the risk of death by the addition of darolutamide or the triplet therapy. And this combination was approved just recently in August of 2022. The study also looked at key secondary endpoints, which showed that the triplet was also associated with a longer time to castrate resistance disease and a longer time to pain progression. So that means patients on the triplet therapy really had their symptoms improved. The study also looked at the association between PSA response and overall survival. So darolutamide plus ADT plus docetaxel significantly prolonged the time to PSA progression. Also, undetectable PSA was achieved in more patients receiving the triplet therapy. So at 24 weeks, there are about almost 50% achieved PSA that was undetectable versus 24% on the placebo. At 36 weeks, 57% versus 25%. And at 52 weeks, 60% of the patients achieved undetectable PSA versus 26%. And for the overall population, overall survival was improved for patients who achieved undetectable PSA levels versus those who did not. So are there any added toxicity for triplet therapy? No, there were no signals of additive toxicity. Really, the safety is very similar between the PEACE-1 and the Arisons. There are really no differences in terms of toxicity between the two treatment arms. You may see a little bit more hypertension with abiraterone and darolutamide, but really there were no significant differences in terms of toxicity. Finally, I would like to emphasize the use of genetic testing in all newly diagnosed metastatic prostate cancer patients. We know that there's clear evidence that the incidence of BRCA mutations is higher in patients with metastatic prostate cancer than in the general population. So somatic and germline molecular testing really can help us make decisions later on. And I always let patients know that about 10 to 15% of the time, we will find something directly actionable that we can target. So when I talk about germline testing, it means what's going on, what's happening in the family, what is being inherited from mom and dad. And it's recommended for all patients who have a personal history of prostate cancer, whether they have metastatic, high risk localized. In patients with Ashkenazi Jewish ancestry, I always recommend germline genetic testing and family history of high risk germline mutations and a positive family history of cancer. And somatic tumor testing is what's going on in your tumor. I always recommend a biopsy to run somatic testing to see if there are any actionable mutations that we can target. So I'll go over the actionable mutations in the later slide, but really the take-home message is across all guidelines, all men with metastatic prostate cancer should qualify for consideration of germline testing. And if the testing is positive, genetic counseling is recommended. So what are the biomarkers that we can look for? So we can look for BRCA1, BRCA2 that can predict benefit from PARP inhibitors, which have been approved for these mutations. We can also look for other homologous recombinant repair alterations that can predict benefit from PARP inhibitors. We can also look for MSI and tumor mutational burden to select for immune checkpoint inhibitor therapy. We can also look at aggressive variants that may possibly enroll patients in clinical trials or use chemotherapy, carboplatin on top of, docetaxel or other chemotherapies. We can also look for PTEN deletions and PI3K inhibitors that will help enroll them into clinical trials. So it's very important to do molecular and genetic testing to have implications not only for their family members, but also for future treatment. So here's a decision tree, and here's really a simple way that I think about who gets doublet versus triplet for any newly diagnosed hormone-sensitive prostate cancer. The first thing I think about is, does this patient have high volume disease? And if a patient has high volume disease, I ask, is this patient fit for chemo? Because I am really keen on giving the patient chemo in addition to ADT and an AR targeting agent to make a triplet combination. If the patient is not chemo fit, I would give doublet therapy with ADT and an AR targeting agent. Now, if a patient has low volume disease, I would give the doublet also. And I also think about whether I can radiate the primary prostate. And this is all for de novo metastatic patients. For recurrent patients who progress to metastatic disease after surgery or radiation, they have a little bit of higher bar to meet in order for me to give them chemo. It does have to be high volume recurrent disease for me to consider giving chemo. Most of the time, I would give a doublet therapy. So again, who is the ideal patient for triplet therapy? They're young, they're reasonably healthy, they have very aggressive disease, widespread, high volume, high risk disease, and they're usually symptomatic. And who is the ideal patient for doublet therapy? It's everyone else who is not fit for chemo. I'm going to see, I think there's some chat messages. So Why is there such poor adoption? What is their rationale? I think a lot of it has to do with, not understanding the clinical trial and, in areas where they don't have access or financially, or sometimes insurance can inhibit it. So this is just real world data. And we know that definitely we can do better by educating clinicians about the benefit of overall survival in terms of triplet therapy. And your view of hormone suppression vacation treatment with high dose testosterone in metastatic hormone sensitive prostate cancer. For hormone sensitive prostate cancer, I do not do high dose testosterone. That is definitely not indicated. We have very, very good treatment in this space that can improve survival. So there is no role for high dose testosterone, and there's really no role for hormone suppression. What is your view of Regolex? I use it all the time. I think it's a great oral drug, and it's an option for patients who don't want to have Lupron, in their system for 3 months. If they have side effects, it's a quick on, quick off. So I use Regolex all the time. Cabazitaxel any better? It's a different side effect profile than docetaxel. It does have less neuropathy. So in patients who have pre-existing neuropathy, I go to cabazitaxel first. The data shows no difference in toxicity in triplet treatment. What are the quality of life effects differences, if any? That's a really good question. So in terms of quality of life, it has definitely seen an improvement with the triplet as well as the doublet therapy compared to the placebo. So again, if patients that are symptomatic, I would definitely do the triplet to improve their quality of life. So it has been shown that the triplet as well as the doublet improves quality of life, but not much difference in toxicity. Where does lutetium fit in? So that's a good question, and I'll go on to talk about that in the later slides when we talk about novel triplet therapy approaches. And what is PARP inhibitor? So PARP inhibitor, it is a mechanism where it inhibits DNA replication, and it's particularly useful in patients who have DNA repair alterations such as BRCA or the family of BRCA. And we use PARP inhibitors to try to target the BRCA mutation so we can inhibit, prevent DNA repair. So it's one of the targeted therapies for BRCA mutation. Okay, I hope that addressed all the questions. I'm going to go on. So there are ongoing metastatic hormone sensitive trials. So again, not all patients are candidates for docetaxel. And also there's some biomarker enrichment or other novel combinations that might lead to having alternative triplets as an option. So here's a summary of really novel triplets with PARP inhibitors that affect DNA damage. So niraparib, talazoparib are all PARP inhibitors that are combined with androgen receptor targeting agents. And I think there was a question on lutetium-177. So this trial, PSMA addition, looked at lutetium-177 combined with an AR targeting agent in newly diagnosed hormone-sensitive prostate cancer patients. So this trial is very good as a novel way to treat patients that can spare them of docetaxel chemotherapy. And this is available at City of Hope as well as in other institutions. There are also other novel treatment approaches using immunotherapy, pembrolizumab, sembelimumab, atezolizumab, and other targeted therapies, cabozantinib, and PTEN inhibitors, and abemaciclib. So stay tuned for these novel triplets that are currently being conducted in clinical trials. So now my last two slides are conclusions, take-home messages. So again, metastatic hormone-sensitive prostate cancer is really a key opportunity to make long-term impact on cancer control by intensifying treatment. So really ADT intensification is the current standard of care. And we have over 9 clinical trials that enrolled over 1,000 patients. So over 9,000 patients that all supported the use of treatment intensification over ADT alone. So for my de novo high volume that are fit for chemo, I used a triplet. For the de novo high volume that are unfit for chemotherapy, I used a doublet. For my de novo low volume, we use at least a doublet. And for some patients, I discussed a triplet therapy on a one-on-one basis. If they're young, if they're fit, and I want to be aggressive with them, I do discuss triplet therapy for my de novo low volume. And I always discuss the role of radiation to the prostate for my low volume patients. For recurrent patients, whether it's low or high volume, I use the doublet. And for some younger patients who have recurrent disease, high volume, I can discuss triplet therapy. And again, ADT by itself is not adequate, but I do, under very, very, very unusual circumstances, I do, if they're frail, very elderly, or if they have significant medical comorbidities, I would use ADT by itself. So really there's room to improve. We need novel triplets. So I showed you a list of ongoing clinical trials with novel triplet therapy. We do need biomarkers to identify populations in whom a novel triplet might be highly successful. And again, germline testing is always necessary for all newly diagnosed metastatic prostate patients. It has implications for family members as well as for future treatment planning. Thank you for your attention.
Looks like we have a new one here. If one is on blood thinners, how does it affect? And if we can, and if I can take hormones for therapy.
Okay, so there's some, drug-drug interactions. Let's say, I know for one is Eliquis, can have drug-drug interactions with apalutamide, as well as enzalutamide. So if you are on blood thinners, then I would consider changing the blood thinner. That would not affect the hormone therapy, or I can, play around with the dosage for the hormone therapy, but it can have drug-drug interactions.
Outstanding. Dr. Metzger, did you have any other questions?
Well, thank you very much for a wonderful talk. It's very complete. It certainly answers a lot of the questions we've had. Dr. Manish Aaron at USC is doing a radical prostatectomy to treat the prostate in oligometastatic disease.
Yes.
And getting about the same, he says, results as the radiation. Is that something they're doing at City of Hope?
Yeah, so we have a trial that is looking at that. At this time, it's not standard of care. So if patients are thinking of surgery rather than radiation, I would definitely consider enrolling them in a clinical trial to address that question. But yes, there are now studies evaluating whether radiation or surgery is equivalent in patients with low volume disease.
Yeah. And I'd written that question about the hormone vacation, and I was called away from the computer and didn't hear the answer, but we have a lot of guys that ask about, they read about hormone vacation, taking time off. And it seems like with the relugolix, you get a chance to get the normal hormone level back much quicker. And it just seems to me like that is a very beneficial thing. What do you think?
So again, for metastatic, so I would do hormone vacation or intermittent hormone therapy for patients who have localized disease, who do not have metastatic disease, or who have oligometastatic disease that have all their sites treated. If patients have high volume metastatic disease, I would feel less comfortable in giving them a hormone holiday. If patients respond very well to hormone therapy, I would consider giving them a break, but generally I would not. I would put them on continuous treatment.
Very good. We sure appreciate your talk tonight. It's just great.
Thank you.
So much.
And I think there's one, would you combine PARP inhibitor with triplet to create a quadruplet therapy, or is PARP given at some other time? So At this time, I would not combine PARP with triplet because of the added side effects toxicity. So PARP inhibitors, they can suppress the bone marrow. So you can see a lot of anemia. And along with chemotherapy, it's just too hard on the bone marrow. So I would not at this time. PARP is given, it's already approved in the castrate resistant setting. So that's when I would give PARP, or when they have a BRCA mutation and they progress after frontline treatment, I would give them PARP.
We have an,
Mhm.
I'm sorry. Yeah, we have an important question here from Deb King. Do you know of any treatment recommendations for metastatic cancer, hormone resistant, for someone who is on dialysis?
So someone who is on dialysis, I would treat them the same. So I would give them doublet therapy. So ADT plus an AR targeting agent. You can use all of the abiraterone, enzalutamide, apalutamide in patients on dialysis. It does not affect their renal function. And you can even give chemotherapy in patients on dialysis.
And Ira has one of his excellent questions. How does LU compare to
Cabazitaxel.
Thank you.
So it's,
Therapy trial.
it was studied in the therapy trial, and they found that the lutetium actually was very comparable to cabazitaxel in terms of the progression-free survival. So in terms of sequencing, if patients do progress on docetaxel and an AR targeting agent, we can do lutetium before cabazitaxel.
Very good.
Okay.
We have a situation developing in we often suggest second pathology consults because we know that a lot of times it gets changed and it makes a difference. AI, whether they go on AS or not. We've just lost for a while our Johns Hopkins guy. Does City of Hope have a program that they do second opinion path?
Yes, absolutely. So we have a very robust GU pathology department. They are always on with us when we talk about GU tumor board. So if anyone wants to send their specimen for a second opinion, definitely City of Hope can be a good place to review it. And they do it mostly at the Duarte campus.
Okay.
Very good.
Would you be kind enough, please, to send us that information or send it to Dr. Metzger?
Yes.
And we will incorporate that into our support groups as to who we should address that to, mail stops, things like that.
Yeah, absolutely. I'll give
great.
them the information.
I think I read the doctor just asked your question.
Yeah, we have a dedicated GU pathologist, if that's what you're asking.
Right, dedicated to prostate cancer, is that right?
Completely dedicated to prostate cancer. He only reads prostate. He doesn't read anything else. He's not a general pathologist.
Okay, thank you.
Very good.
I have a question.
Yes.
Hello, doctor. Very good presentation.
Thank
Let me see if I understand this correctly. Your triplet that you refer to may be abiraterone and prednisone and chemotherapy. You add the chemotherapy. Let's see. You don't add the chemotherapy. How to form this? You're not suggesting to wait until the abiraterone and the prednisone becomes resistant,
No.
and then add the therapy. You put all three together from the beginning. Is that right?
From the beginning, when the patient is castrate hormone sensitive.
Okay.
Yeah, I don't wait until they're resistant. So again, you get more bang for your buck when you use it up front than waiting.
Okay. Thank you.
I have a question.
Excuse me.
I have a question. On the first 6 months, when I have the bialutamide therapy, the first 6 months I have a blood thinner because they put a stent on my heart. That's affecting anything for the treatment?
No, if you have good kidney function,
Yes.
then that should not affect treatment. And if you're fit for chemotherapy, you can get it. But definitely hormone therapy, it should not affect it. And
Yeah,
it can improve.
Yeah, I have 6 months hormone therapy, and after they did the radiation, and after I have up to the 1 year hormone therapy, and right now they stop because they worry about it for my heart.
Yeah, yeah,
Thank you very much, doctor. Thank you.
sure.
I have an additional question though that just occurred to me. When you use abiraterone, you have to use a steroid. Does that influence you maybe using one of the other ones?
Depending on the comorbidity of the patient, if the patient has, diabetes that's not well controlled, congestive heart failure, I would avoid abiraterone with prednisone. I would choose darolutamide instead. Darolutamide is very well tolerated. So depending on the patient's comorbidity, if they have hypertension, I would try to stay away with abiraterone, things like that.
Very good. Again, we really appreciate your effort tonight. Thank you.
Thank you.
Anyone else? Deb, did we answer your question about dialysis? I know you're on mute right now.
Yes, I think that was fine. Thank you so much.
Okay.
I did have another question about the group that's doing the review of the samples or the specimen for the biopsies
Yes,
at the Duarte campus. Do they also review PSMA PET scan results?
they do. So we
Okay.
have dedicated nuclear medicine that specifically looks at PSMA PET.
Okay, wonderful. Thank you.
Mhm.
Anybody else?
Great effort.
Well, thank you very much, Doctor, for making this a very, very interesting evening. We are looking forward to having you back. The doctor is at the Irvine campus for City of Hope. I think we have contact information here. If not, check your Google for City of Hope in Irvine, and you can contact the doctor.
Yes.
If there are no other questions, we can hope to see you next Tuesday at our support group meeting at 5 p.m. Pacific. Watch your emails.
Thank you.
Doctor, thank you and have a great evening.
Thank you.
Good night, all.
Thank you very much.
Thank you very much.
Very helpful.
Thank you.
Thank you.